at 3600 Civic Center Boulevard. My name is Holly Fernandez Lynch, and I co-lead the Research Ethics and Policy series with Steve Jaffe. And today we're really pleased to welcome Dr. Alexis Thompson for her lecture titled Gene Therapy for Sickle Cell Disease, Research Ethics and Policy Implications. I'll introduce you more fully in just a moment. A couple of announcements. We will not be having a reps lecture in March. There's a scheduling conflict that came up, and so those speakers will be joining us in the fall. We'll be back together on April 14th in this same room and online, and we'll be joined then by Bob Cook-Deegan from Arizona State University, who's going to deliver a lecture on building a better NIH. You can see some of our other upcoming speakers here on the slide, and then also on the Department of Medical Ethics and Health Policies website on our events section. You're also always welcome to share ideas for speakers that you'd like to see with me or Steve. No promises we can get them in the door soon. We have a fabulous list extending over the next year, but we are always interested in folks who would bring interesting and unique perspectives regarding research ethics and policy issues. We have a couple of online resources that I want to make sure everybody is aware of, including a short research ethics course that's available for free continuing education credit and can also be used to satisfy the research ethics training requirements at both Penn and CHOP. And Lisa will share a link to that in the chat. And then finally, a quick thank you to all of our wonderful reps co-sponsors, which you see on the slide, as well as thanks always to Lisa Bailey for her support of this series. So it's now my pleasure to introduce today's speaker, Dr. Alexis Thompson, who is a professor of pediatrics here at Perelman School of Medicine and also holds the Elias Schwartz Endowed Chair in Hematology. Her clinical interests include hemoglobinopathies, including thalassemia and sickle cell disease, and stem cell transplantation, including gene therapy. Her most significant scientific contributions are clinical and translational studies to better understand and treat hemoglobinopathies. I practiced that word before we came. She's been a leader of the American Society of Hematology, including serving as that society's president in 2018. And as part of that role, Dr. Thompson helped to develop a national sickle cell data collection platform and implement newborn screening and early intervention efforts in sub-Saharan Africa, where the burden of sickle cell disease is profound. She received the ASH Award for Leadership in Promoting Diversity in 2023 and was elected to the National Academy of Medicine in 2024. We're really thrilled to have you here today. We, as always, will take questions after the lecture from those of you who are here in the room, of course, as well as those of you who are online. Lisa, you can tell me, does this room also have the same microphone capacities for people online? Okay, so you should be able to state your own question, or if you want to put it in the chat, I'm happy to read it out for you. We are recording today's lecture, and you'll be able to find it on our department's website very soon. And with that, I will welcome Dr. Thompson up.
Thanks for the introduction, Holly. I'm looking forward to actually hearing about building a better NIH in April. So maybe I'll be back. But really, thank you so much for the invitation. Ironically, I actually started this journey in this lecture, part of the lecture that I'm giving today, actually at the NIH last January. And so I creeped in there right before perhaps a few things changed. But I'm happy to share with you where this journey continues, really focusing in on some of the ethical and policy implications for what is otherwise some very exciting advances in the field. And these are my disclosures. So I will start with my inspiration for this talk. And I suspect that many of you, hopefully some of you have seen this monument in Washington, D.C., or are familiar with this quote from Martin Luther King Jr., that we shall overcome because the arc of the moral universe is long, but it bends toward justice. And these powerful words were spoken initially in 1968, which for many people would say that this was the most tumultuous year in this country's history. One that was actually, the signature of it was really broad political unrest, including political violence. And in fact, Martin Luther King died less than a week later as an assassination. But yet when he spoke these words, his purpose was to inspire hope and to give people a focus that even in the presence of amazing uncertainty, that we needed to come together and have the courage to look forward. So what I hope to cover today is reflecting on some of the scientific advances in sickle cell disease, including gene therapy. I think you can't do that, however, without acknowledging sickle cell as an interesting study of the complexities of race and science. And then to continue to ask the question, what are the ethical and policy hurdles that remain? What I hope to also do is to construct perhaps a different question, and that is, can we examine the long biomedical arc for sickle cell disease and to determine whether we can bend it toward health equity? For those in the room, and I apologize if there are any hematologists in the room for the simplicity of this slide, but just to do level setting, wanted to just cover briefly what is sickle cell disease. It is caused by a very simple genetic mutation in the beta globin gene. And beta globin is one of the key building blocks of adult hemoglobin. It's inherited in an autosomal recessive fashion, and it affects millions worldwide. Fortunately, in this country, we have newborn screening, and many high-resource countries have some form of early screening. And we clearly know that with screening, we can reduce morbidity and mortality. But sickle cell, in its simplest form, is a hemolytic anemia that can be potentially life-threatening. So this very simple mutation in the beta globin gene causes a change in the molecular structure of globin such that its properties are changed in that under certain conditions, primarily under the conditions of acidity or high or low oxygen, sickle hemoglobin polymerizes where normal hemoglobin would not within the cell, causes the cell to become very rigid, more prone to being fractured or hemolysis, but also to become to obstruct small blood vessels, primarily capillaries. This can result in a severe hemolytic anemia that can be potentially life-threatening, but also causes chronic organ injury and early death in patients with sickle cell. As a clinician, this disease is quite difficult. It often has not only these chronic things to think about, but there are some major medical emergencies that occur as part of this disease. It has a long arc, suffice it to say. Sickle cell was first described in the Western literature, although not the first time it was ever described in humans, but in the medical literature in 1910. And over that first century, a lot of this was about discovery, with sickle cell being a condition where we began to look at some of the very fundamental things about structure of DNA, isolating proteins, but not many of the discoveries that occurred in the first 60 to 70 years after it was discovered really informed our knowledge about science and about this disease, but unfortunately not necessarily translate into anything measurable in terms of helping people with this disease. Having said that, if I'm looking at the last decade or two, I think that there have really been some amazing opportunities to see some advances that really are really reaching the bedside. And I think that that's highlighted in this slide, which I often share with medical students. So when we talk about healthcare disparities, it's just pretty plain that in sickle cell disease, again, so that first almost century of work in sickle cell led to the life expectancy really not doing much. But since the 1980s, seeing an increase in the trajectory, in part because of a few of the actions that are noted on this slide. But even now, so this only goes to 2000, but even if I project into 2025, there remains a lag between the life expectancy of individuals with sickle cell disease compared to all Americans. And so certainly an opportunity, even today, the gap is still between 20 and 30 years life expectancy for sickle cell compared to all Americans. How common is sickle cell? We estimate that there are about 100,000 Americans who have sickle cell. 1 in 12 African Americans are carriers for sickle cell disease, or they have a single gene mutation, single allele that's abnormal, so they have sickle cell trait. And about 1 in 370 babies born to African American families has sickle cell disease. One thing that's also worth noting is that 1 in 10 babies today that have sickle cell disease are not of African ancestry, they are Hispanic. And so it's also important for us, and in fact underscores the importance of universal screening so as to not miss these children. Sickle cell is a single mutation that only involves a protein that's produced in red blood cells, yet there is not a single organ system in the body that is not impacted by this disease with either acute or chronic complications. And so I share this slide with the medical students because I wish there were more hematologists in the audience, but there certainly are orthopedic surgeons, there are obstetricians, there are general surgeons, there are radiologists, there are ophthalmologists, and really I can find something for you in sickle cell disease. And so really impressing upon people that no matter what specialty they go into, this is a condition because of its complexity they are likely to see, but also because of that is a disease for which finding effective therapies has been a bit elusive. Hydroxyurea is the backbone of therapy for sickle cell disease. It was the first FDA-approved drug for sickle cell. And it works in multiple ways. It's an old chemotherapeutic drug. It was appreciated in patients who were receiving it for chemo that they had an increase in their fetal hemoglobin, and fetal hemoglobin is non-sickling. And so it raised the question, could you actually take this agent that actually induces fetal hemoglobin and actually have a therapeutic benefit in this very different disease? But it also has other mechanisms. So in addition to inducing fetal hemoglobin in red cells, it also causes some degree of myelosuppression, which should control to some degree inflammation. It improves anemia because these are red cells that are less likely to hemolyze. It reduces hemolysis, but also increases NO bioavailability, which improves the quality or the vasoreactivity of blood vessels. It's also been found to reduce sickle cell pain and acute chest syndrome, and that really is where the rubber meets the road when it comes to the benefits to patients, having fewer admissions, shorter hospital stays. But there are many, many, many barriers to its use. More recently, there have been additional indications in children, and I'll describe a little bit of those. But certainly, this is the backbone of therapy for sickle cell. And this is a slide that I've doctored a little bit, courtesy of my colleague Russell Ware at Cincinnati. And there are a number of things I want you to take away from this one. One is the proof of principle in 1984. This is actually this was actually the first attempts to actually look at hydroxyurea in adults, leading to the MSH trial and ultimately the FDA approval in adults for sickle cell in 1997. There are a number of other key clinical trials, many of which involve children that have occurred since then. But I want to highlight the anchor of 1997 and 2017. So this 20-year span where there were no new drugs that were developed for sickle cell disease. And so when you think about diseases like cancer or diabetes or heart disease, pick whatever major health threat you want to think about. If you only have one agent that's ever been developed for that disease, it sort of is not surprising that the progress that you are making to benefit patients is going to be limited. Having said that, since 2017, there have now been a few new agents that have been developed. I also call your attention to the blue asterisks out on one end of the slide, because these actually are clinical trials that either partially or entirely were run in low and middle income countries. And many times people think that it is nearly impossible to actually perform effective research, including randomized trials in places like sub-Saharan Africa. These trials were run effectively in collaboration with investigators in Africa, collaborating with investigators in the United States and the UK for the most part. And they also found that even in a malaria endemic area, that hydroxyurea could be safe and effective in sickle cell disease. There are a few other choices that have come online since 2017. So I mentioned hydroxyurea, which we now introduce in asymptomatic children before 1 year of age. It does have some side effects, but we think that the risk outweigh the benefit. The benefits outweigh the risks for use of hydroxyurea. L-glutamine or Indari reduces red cell oxidative stress and can be used daily for patients over the age of 5. It has a fairly high pill burden associated with it and some side effects which many families find objectionable. So really haven't seen much of an uptick in that one. Voxelotor was the first rationally designed drug for sickle cell disease and its primary benefit was increasing total hemoglobin. Unfortunately, it was withdrawn from global markets by the manufacturer in September of 2024. And crizolizumab is a medication. It's an IV infusion that's a p-selectin inhibitor, and so reduces the adhesion or the tendency of sickle red blood cells to adhere to each other and to adhere to the endothelial lining. It's given once monthly for adolescents and adults with sickle cell to reduce the severity and frequency of pain. So not a lot, but definitely some improvement. And having said that, what I'm more encouraged by is that there are many additional agents that are in the therapeutic pipeline. But I think that we should have no illusions that there will not be 30 drugs on the market tomorrow for sickle cell disease. I think what it speaks to is that if we are not willing to actually, sort of public and private partnerships, begin thinking about and identifying either newly designed drugs or repurposing drugs, that we can't make progress. But yet I'm quite hopeful that somewhere in that 30 there will be one or more blockbusters for people with sickle cell disease. So I've talked a little bit about drug treatment. I'm going to touch a little bit on allogeneic transplant, but we'll spend most of my time talking about ex vivo gene therapy, touching briefly on in vivo gene therapy. When it comes to curative therapies in sickle cell, or what many of us call transformational therapies in sickle cell, the fundamental one is allogeneic transplants from related donors, usually siblings. But there is actually some compelling data in allogeneic unrelated and more recently in haploidentical transplants, particularly in adults. I'm going to be focusing, however, on gene therapy, which is not just one thing. It includes gene editing, gene addition, as well as now base editing. These are results from 1,000 individuals. So this is a compilation of 1,000 transplants performed around the world using sibling donors. And I think the two take-homes are really the remarkably low rates of chronic graft versus host disease, which can be an absolutely devastating complication of allogeneic stem cell transplants, and the really impressively high survival, especially when the source of the stem cells is either bone marrow or cord blood. Umbilical cord blood is very rich in hematopoietic stem cells, but certainly with either one of those options, and to a lesser degree with peripheral blood stem cells, you can see stable overall survival. That survival is best when it's done in people who are young, so under the age of 14. And certainly in the most recent era, since 2006, where we arguably are doing better at supporting patients through transplant. So we've certainly seen better survival in people who've had transplants more recently. But certainly at this point in time, matched sibling donor transplant should be considered standard of care for patients with severe sickle cell disease who are interested in looking at curative options. I'm not going to talk about the other kinds of haplotransplants, but what's most important, though, is to note that most patients with sickle cell will not have a donor of any kind, either a matched sibling donor or even an unrelated donor in the National Marrow Donor Program or any of the other international donor registries. There are some open research studies that are looking at unrelated donor transplants, as well as haploidentical transplants, as well as reduced intensity transplants to try to make them safer. But there are potential complications that are unavoidable. So I've already mentioned graft versus host disease, both in acute and chronic form, which can be fatal, non-engraftment or graft failure, severe infections that are related to the immune suppression that comes with transplants, infertility, which is not insignificant, and then transplant-related deaths. And so certainly not only are there not donors, but some of these risks certainly have limited the uptake of transplant for sickle cell disease. And so it begged the question, is there something more that we can do? And that really is where gene therapy comes in. There are a number of ways to think about gene therapy strategies. The first is straightforward gene correction. And let's just say that is not what we're capable of doing today, where one could imagine truly looking at replacing the sequences at the site of a native gene or removing a native gene and replacing it with a perfectly normal copy. That does not happen, yet certainly is aspirational. Instead, gene addition would introduce a normal copy of a gene, but it will leave the native gene intact. And that is important when we look at the current approaches to sickle cell disease. We can modify the expression of other genes that play a role in disease phenotype or pathogenesis, and that is also an approach that's being used in sickle cell disease. And then finally, genome editing, where we directly repair specific sequences. Sickle cell disease is currently only being used as an ex vivo form of gene therapy. And the fundamental thing is that the patient is their own donor. And so it eliminates that barrier of having a sibling donor or an unrelated donor. And it is only ex vivo for now, where cells are removed from the body, they are modified in a laboratory, and then reinfused after chemotherapy is given. And looking at some of the strategies, this is how they play out in sickle cell. If we add a normal copy of a beta globin gene, again, it's leaving the native gene intact. But as long as there's pancellular expression of this new gene, you could essentially convert someone from sickle cell disease to basically having sickle cell trait. We know that people with sickle cell trait, by and large, are asymptomatic and they live a normal lifespan. So I think for many people, that would be more than acceptable as an outcome. Moreover, in many people who have had sibling donor transplants, their siblings had sickle cell trait. And so they have been cured, but yet they have trait. And so I think, again, that really may very well be an acceptable outcome. You can increase fetal hemoglobin because fetal hemoglobin is non-sickling. You can do that by either adding more capacity of gamma globin, which is one of the key building blocks for fetal hemoglobin. You can make beta globin more gamma-like so that it's less inclined to sickle, or you can alter the expression of a gene that regulates fetal hemoglobin production. And as I already mentioned, that there are 3 different types, and I'll walk through each one of these and the progress that we're making with them. I'm going to talk a bit about lentiglobin BB305, which is the lentiglobin vector that we understand the most about in its application in sickle cell disease. This is a cartoon of BB305. It is a replication defective, self-inactivating lentiviral vector that produces a beta A that's called T87Q because it contains a single amino acid substitution. It is under the control of the beta locus control region, which is the normal sequences that control erythroid-specific expression of the beta globin gene. But that amino acid substitution is important because that T87Q is actually the natural sequence in gamma globin. And so that particular sequence is part of what inhibits sickling. And so it inhibits polymerization. But the other thing that it does that allows us to actually track the expression of it in peripheral blood because the HPLC migration of beta A T87Q can be detected separate from beta A, which would be from our blood banks, beta S, which would be the patient's natural hemoglobin, as well as some other hemoglobin variants. And I'm going to give you an overview of lentiglobin gene addition, but I will tell you there are aspects of this that are now really pretty much the standard of care for gene therapy for the hemoglobinopathies. And that begins with stem cell collection. In the case of sickle cell, it's with single agent plerixafor, which is given to actually mobilize stem cells from the bone marrow out into the peripheral blood temporarily. In the case of thalassemia, we use GCSF plus plerixafor. They are then collected by apheresis, and the apheresis is usually carried out in 1 or more cycles, and a cycle lasts about 2 or 3 days that the patient is hospitalized. At the end of the mobilization and apheresis process, their cells are then sent to a centralized manufacturing facility where what we call the drug product is prepared. The drug product is actually their own stem cells that have now been modified. And in the case of lentiglobin BB305, it is those cells being transduced with a lentiviral vector that produces T87Q. Those cells are then cryopreserved. They are tested for safety and before they are released back to a clinical site. During that time period, the patient otherwise is going about their lives. I will tell you that the time that it takes to do this part of it probably is about 3 to 6 months from the time that they originally have the conversation, that the patient says, I'm a go, that their organ function we determine is sufficient for undergoing gene therapy, and that we collect enough stem cells to actually say that we have a drug product that's sufficient to actually reinfuse. Then the patient is actually recalled. They're admitted to an acute care facility where they undergo myeloablation, and by and large, the primary agent that's used is busulfan. Myeloablation is absolutely critical. There have been a few early trials that did not use myeloablation that were not successful. Myeloablation does 2 things. It simply makes space in the marrow to actually have these stem cells return to the marrow and then sit down. there are no, today, there are no clinical trials or programs that actually have stem cells that have a survival advantage. And so if you don't make space for them, they will simply be crowded out by the patient's own cells. The other is that we want to reduce the overall number of cells that still will produce sickle hemoglobin. And so busulfan will accomplish both of those things. Well, the patient gets 4 days of busulfan myeloablation. They then have their drug product reinfused. It takes about 10 minutes. It is the most uneventful thing you ever want to imagine. That is probably the key point in this entire thing. The patient remained hospitalized largely because of the side effects of busulfan. But eventually, during that hospitalization, we hope to see those transduced hematopoietic stem cells begin engrafting, that their platelet count and their white blood cell count returns, and that most importantly, they begin producing red blood cells that now hopefully have taken up the gene product. And so that they will hopefully begin producing, at least in the case of lentiglobin, a gene therapy derived hemoglobin A T87Q. In the research studies, they are followed for a total of 2 years, and then they go on to long-term follow-up. I will just tell you that the FDA expects us to do long-term follow-up even now in the commercial setting, which in and of itself is going to be one of our ethical challenges. This is actually some of the data that actually informed the approval of lentiglobin by the FDA. These are swimmer's plots for those who aren't familiar with these, and each one of these lanes is an individual patient. And the red symbols represent an admission for a vaso-occlusive pain episode for sickle cell in the 24 months prior to gene therapy. Day 0 is the day that they actually received their cells, and then the blue after that is the time period after. And what you can see in this one is that 32 of the 34 patients in this initial wave of patients achieved complete resolution of severe pain following gene therapy. And that those few who still continued to have some pain episodes, that they were less frequent and that their hospitalizations were much shorter. Another approach was gene editing, and this is the first time that CRISPR-Cas9 was used in a human disease. And in this setting, this is an example of actually targeting a gene that actually is important for the pathogenesis of the disease. And so this is targeting a gene called BCL11A, which does not encode hemoglobin. It is a primary regulator in that it actually is responsible for, it encodes a transcription factor that's responsible for repressing fetal hemoglobin. And so this is part of the natural process where humans switch from fetal hemoglobin, which is what we make during our prenatal life, and we stop making by the time we're about 6 months of age. We switch from making gamma globin to making beta globin, which is part of hemoglobin A, and in fact is only sickle hemoglobin in someone with sickle cell disease. And so the idea is that BCL11A is a negative regulator, and so it's responsible for turning off gamma globin because it binds to the promoter of gamma globin. If you could somehow prevent the expression of BCL11A, could you turn fetal hemoglobin back on? And that was precisely the approach that was taken in this clinical trial, where CRISPR-Cas9 was used to target the enhancer upstream of BCL11A. Ask the question, if you could turn that off, could you actually turn fetal hemoglobin back on? And these are the results that led to the approval of this drug. Again, you'll see in this case blue markers, but you see how frequently these are people who are being admitted for vaso-occlusive pain episodes in the time period prior to gene therapy. Time 0 is the time that they got their medication. A brief period of recovery, and then the time afterward. And what you can see is, again, almost 94% of people in this clinical trial were pain-free after gene therapy. There was one death in this study, and it was to someone who died of COVID. These trials began before the pandemic and continued through the pandemic. This led to the FDA approval in December of 2023 of both of the agents that I've just described. So Casgevy or Exocel was from Vertex, and that is the CRISPR-Cas9 approach, and Lyfgenia or Lovocel, which is lentiglobin BB305 from Bluebird Bio, which is now called Genetics. They have both been approved for people over the age of 12 for similar indications in terms of which sickle cell subtypes. And you can see the price tags for each one of them, 2.2 and 3.1 million. I'll come back to that part of it. I want to continue on talking about the Beam 101, which is the current open clinical trial that I personally am quite excited about. And this is recreating a condition called the hereditary persistence of fetal hemoglobin, which is a naturally occurring condition of individuals who have mutations. Some of them are in the promoter of the gamma globin genes that actually results in the persistent production of fetal hemoglobin naturally. These are individuals who are entirely asymptomatic. And if you co-inherit HPFH with sickle cell, you have a remarkably mild form of sickle cell disease. And so the thought would be that if there was any way for us to actually then introduce a different kind of mutation, could we actually achieve some similar goals? Beam 101 uses base editing, and base editing has a distinct is distinct from CRISPR-Cas9 in that CRISPR-Cas9 requires a double-stranded DNA break in order to make the mutation that's necessary for BCL11A. In this case, the mutation is not in BCL11A. It's actually in the binding site of BCL11A in the gamma globin genes. And with using base editing, it's an adenine-based editor. You do not have to it does not create a double-stranded DNA break, and so may inherently be safer. As it turns out, it's not only safer, it's probably gentler on stem cells, but we'll talk a little bit more about that one. But the idea being that if we could somehow disrupt the BCL11A binding site in the promoter regions of the gamma globin genes, could we actually see fetal hemoglobin turn back on? And so that's what the Beam 101 trial is. And again, patients who were having frequent admissions for vaso-occlusive pain episodes, and then no episodes of pain following that. Now, this trial has shorter follow-up. But yet it's been remarkable. What I'm not showing on this slide, but I have another slide that I'm not going to share, is how quickly these people actually recover. So many of these people are neutropenic for less than 10 days. And many of them are out of the hospital in less than 30 days. And many of them, their fetal hemoglobins, which I'll show on the next slide, are well over 60%. And so clearly something about this approach may really be quite remarkable. There was one death in this study for someone who had fully engrafted, sadly, and actually had strong evidence of fetal hemoglobin induction. This person died of respiratory failure, which was attributed to a combination of busulfan, which is known to cause pulmonary respiratory failure, as well as vaping. This is what I was alluding to in terms of the frequency of fetal hemoglobin induction. And what you can see is that by 2 months of age, nearly half of their hemoglobin in blue is actually fetal hemoglobin. And in many instances, when I'm talking about hydroxyurea, a home run for me in hydroxyurea is getting 20%. With using disease-modifying therapy. And so I'm getting twice as much of that within 2 months. And again, the longer out we follow people, the more we're seeing. We've done 4 of these now at CHOP, and they're all similar. I mean, they all have fetal hemoglobins that are well above 50% in a very short period of time. It is not without risks. And so, as I mentioned to you, busulfan is a current agent for that. And so the acute upfront things are not only mucositis, pharyngitis, really the entire intestinal tract just kind of breaks down, but which is really extraordinarily painful and debilitating to patients temporarily until they recover from the transplant. Hair loss certainly is a known risk, some nail change and a few other things like that. Liver problems called veno-occlusive disease is the principal one that we have to be on the lookout for. Pulmonary fibrosis and respiratory failure I just mentioned, and then the risk of secondary malignancies, which is known with busulfan, we think is between 2 and 5%. Graft failure has been a concern with gene therapies, and so all patients who undergo gene therapy today have an aliquot of their unmodified stem cells that are retained at the clinical site. So if a patient by day 40, day 45 shows no evidence of recovering, they will be given their own unmodified stem cells back. Having said that, today there have now been hundreds of these done, and not a single person has required their stem cells back. The early forms of gene therapy using gene addition and gene editing were associated with delayed platelet engraftment compared to allogeneic stem cell transplant. When we think about insertional gene addition, clonal dominance or insertional oncogenesis continues to be a theoretical concern in terms of looking for potential locations. You can imagine in the genome where if you have new DNA inserted into a hotspot, the risk of insertional oncogenesis. There have been 2 cases of AML in patients who had lintyglobin BB305, but neither of those cases, when they were adjudicated, were found to be related to the actual gene therapy. Off-target gene editing continues to be a theoretical risk with CRISPR. There have been instances of off-target events, but that they have not been clinically significant. And then infertility, again, largely because of busulfan, but to some lesser degree, an inherent part of sickle cell disease continues to be a risk. And I will tell you, there are many patients who forego gene therapy today because they do not want to risk infertility. We would certainly offer fertility preservation for all individuals, both and certainly in the clinical trial setting. This we hope is the future, and that is using some form of in vivo gene therapy, which would negate the hospitalization, negate hopefully the use of chemotherapy, and could conceivably be used in wider settings. This is work that was actually piloted here at CHOP and Penn, looking at in vivo hematopoietic stem cell mRNA delivery using nanoparticles, with very impressive results both in the laboratory, in non-human primates as well as humanized mice. And so really, LNPs are not the only approaches being considered, but I think many of us think that in vivo approaches will likely be the future of curative therapies, not only because it'll eliminate the stem cell transplant. We hope it will lower the cost of gene therapy and hopefully offer wider availability. Access and equity, though, are really fundamentally the biggest political and policy and ethical issues. Once these new therapies are approved for use, will they be out of reach for some or many? And this is not just gene therapy. These are any number of other really very exciting advances in medicine for not only children, but even for people as they get older. How will we ensure some form of equity in terms of people getting access to them? And I'll touch a little bit on some of the things that are being done, at least in the setting of our current. And that one of them is something called the CGT, or Cell and Gene Therapy Access Model, that was worked on for several years. Had the privilege of working with CMS on this. It finally was developed by CMS on an executive order from President Biden. And went live in January of this year, although states like Pennsylvania began using it 18 months ago. The goals were really to increase access to innovative cares with people who are on Medicaid, to a lesser degree with Medicare, in order to improve health outcomes and to reduce healthcare utilization and expenditures, is really what the model fundamentally hopes to do. CMS will negotiate with pharmaceutical companies to create outcomes-based agreements, including the pricing for gene therapy. So this is not just for gene therapy, but that's the general principle for the CGT access model. States that decide that they want to do this will sign on to an agreement with the manufacturer. And if they decide to sign on, the manufacturer is obligated to provide the agent to the state with a rebate for the cost of the gene therapy product. The states are able to negotiate the cost of gene therapy, and as best I can understand, it is a discounted price. It's heavily discounted. It's negotiated by CMS, but that this pricing is certainly tied to specific patient outcomes. There are some other policy and research implications. Currently, it is restricted by eligibility. It is right now typically being limited to patients who are between the ages of 12 and 35. We could certainly argue that there are probably people who are older than age 35 and younger than age 12 who would benefit from something like this. Right now, it has only been open to the most severe forms of sickle cell disease, so that's SS and S beta 0, although there are patients who have other forms of sickle cell that are arguably very severe. And the definition of disease severity is only about pain, and that is not the only severe complication of this disease. There's also very limited geographic distribution of these so-called qualified treatment centers for either of these FDA-approved products. Now, CHOP and Penn are qualified treatment centers, but arguably, part of it is because the expertise of gene therapy is still fairly narrow, that not every community hospital, not every academic medical center has someone who can say that, yes, I know something about gene therapy. There's also difficulties with actually collecting the stem cells in sick patients with sickle cell disease. It is truly an art form. These are you're trying to actually collect stem cells in the setting of red cells that are sticky and that are rigid, and that are breaking up. And so when you look, or you're looking for this very clear window between the cellular layer and plasma, and instead you're getting sort of this kind of junky pink layer that it really bounces around a lot. And so really, it is really not easy to collect stem cells in patients with sickle cell disease. There also, sadly, has been variable institutional support for high cost therapeutics. I think those are just the realities. There are plenty of institutions who are saying, we're gonna wait on this, or we're gonna ride this one out because we're just not sure we want to take on the risk associated with the cost. Risk of infertility, as I've already mentioned, but also the lack of universal access to fertility preservation is still very much the reality, at least in this country. There are some states that require that if you offer fertility preservation for insured people, you must offer it to everyone. There are some that have recognized that if you are giving anyone an agent that is associated with infertility, whether it's for cancer or otherwise, you must offer them the same other options. But yeah, I can see that it is not universal. There also is not universal access to social and financial support for the frequent clinic visits and the extended hospitalizations that are required right now for gene therapy in its current form. And right now, the expectations are from the FDA that they need to be followed for 15 years. Well, this is a somewhat transient population that has a lot of its own challenges. And so following patients for 15 years is going to be something that I think all of us are going to have to contend with. Sickle cell, as I've already alluded to, is a condition of disparities. And I can't say this enough. And this is a unique disease in that it affects a historically overlooked, underserved, and underrepresented population in this country. The quality of life is compromised, as well as many of the other complications that I've already described, and leading to premature death. Patients are often have inadequate access to high quality health care, and that is just simply a reality in this country, but arguably globally with sickle cell disease. And so really, for those who are interested in disparity or health equity, this really is a really remarkably important disease. And I often am quoting one of my colleagues, Dr. Michael DeBond from Vanderbilt, who said that sickle cell is the canary in the coal mine for health equity. So if we cannot figure out a way to acknowledge that if we could figure out how to actually provide more equitable care to reduce disparities in sickle cell, surely many of the things that we want to accomplish in sickle cell would be applicable to many other types of health equity or health disparities. And, I always apologize if there's a pulmonologist in the room or online. I truly have nothing against people who have cystic fibrosis. I am, in fact, quite impressed with the amount of progress that's been made in cystic fibrosis, but it is very difficult to ignore the differences between these two conditions. Cystic fibrosis and sickle cell are both monogenic disorders that can both be identified in newborns that both, until recently, were associated with a shortened lifespan. There are 3 times more individuals in the United States who have sickle cell compared to those with cystic fibrosis. Yet there is 3 times less NIH dollars that are spent researching sickle cell compared to cystic fibrosis. When we look at things like foundations or private sector, there are 25 times more private dollars that are spent on studying cystic fibrosis compared to sickle cell. When I actually look at the number of dollars per patient who's affected, it is 70 times more dollars are put into actually looking for a cure, or looking for ways to treat cystic fibrosis than there are for sickle cell disease. When I also think about research output, it's not surprising. There are fewer papers that are being published in sickle cell, and there are fewer clinical trials. This paper came out in September of this past year, which is from the National Center for Health Statistics, and it's looking at an age-adjusted mortality trends fairly recently from 2008 to 2023. So when I talk about that biomedical arc, this is looking at cystic fibrosis on the lower and then sickle cell disease at the top. Suffice it to say that much of that investment in the cystic fibrosis is achieving its goal, and that is seeing the downward trend in mortality for cystic fibrosis. It's remarkable now seeing people with cystic fibrosis, because certainly I'm old enough where we were in an era where patients with cystic fibrosis were routinely hospitalized for this course of intensive pulmonary therapy and antibiotics, but they invariably died before they were 20. And now seeing people that are well into their 40s and 50s who are on disease-modifying therapies with cystic fibrosis. So really some remarkable progress, but we are not seeing that yet with sickle cell. The Department of Health and Human Services actually commissioned a report from the National Academy of Medicine to create what was intended to be the new blueprint for action for sickle cell disease. And this is a 500-page report that came out a few years back. And it included 8 different pillars of recommendations for academic institutions, for foundations, for funders, on things that one could do to actually improve outcomes for people with sickle cell disease and sickle cell trait. But one really striking comment was made in the executive summary at the beginning of this one, and that is that improving health outcomes for sickle cell care requires comprehensive team-based care, new payment models, and addressing institutional racism in healthcare. There are any number of sources of systemic inequities and structural racism that we have to contend with. And I think many of us are in our own worlds that involve healthcare: hospitals, academic medical centers, pharmacies, clinics. I get that. Yet that is not where most of us live. And so I think it's important to point out that there are plenty of other sources of systemic inequities and structural racism, many of which impact patients with sickle cell and actually all of us. And so when we think about opportunities to have an impact, one needs to move well beyond sort of our very narrow sphere of healthcare. Can we bend the biomedical arc? Well, actually, there's an additional National Academy of Medicine report that was commissioned by the NIH and ARC to look at what are the major drivers for healthcare inequity. And these are some of their overarching conclusions. And that is that the nation has made little progress in advancing health equity. Racial and ethnic inequities remain as a fundamental flaw of U.S. healthcare. A diverse health and science workforce representative of the community it serves is essential. Emerging approaches to achieving health equity show promise, and they're poised with increased investment. And that finally, continued research and evaluation are needed to measure and drive improvements in health and health equity. I've been talking primarily about the U.S. healthcare system. It's important, though, to remember that the burden of this disease is not in the United States. There are millions of people worldwide, and if we do nothing, the burden of this disease on this planet will increase by 30% by 2050. 75% of that burden will be borne by sub-Saharan Africa. In the United States, we have maybe 1,000 to 2,000 children born every year with sickle cell. There are over 1,000 babies born in sub-Saharan Africa every single day with this condition. 90% of them will not survive into adulthood, even though 98% of children in this country will, and most of them will not see their 5th birthday. And this was a very poignant piece in the New York Times years ago. This is a family that's already lost 3 daughters with sickle cell in northern Nigeria. Will we do anything to save their 4th daughter? And so will all these advances that we're seeing in sickle cell treatment reach those in high-burden countries? The ethical challenges in gene therapy, and there are people who want to think about gene therapy in Africa, are many. Widely available standard comprehensive care for sickle cell across Africa. The concept of informed consent and the comprehension of that consent, as well as variable health literacy, is something that we are going to have to contend with. Transparency of communication, including risk, is also something that many of us are struggle with, including the overestimation of benefit, and clear descriptions of some of the potential adverse events. Criteria for selection of individuals. Many times we think about people who are the most severely affected, but should we be thinking about people who are the youngest and maybe will be the greatest beneficiaries of something like this? And then right now, there's really a dearth of a legal or regulatory framework for using gene therapy in sickle cell, or really gene therapy of any kind in Africa. The cost is certainly something that is being worked on by a number of people. Many of them involve public-private partnerships to lower costs, to look at place of care, biomanufacturing in sub-Saharan Africa and also in India. But it will need to be supported by the World Health Organization and also by the AMA, the African Medicines Agency, which is a relatively new entity to look at tech transfer. So in summary, there's been significant progress in sickle cell, particularly in the last decade or so. Stem cell transplants is now an established therapy for sickle cell, and there's some additional refinements that are under investigation. The early clinical trial results and now the commercialization of gene therapy and gene editing in sickle cell is promising, but the uptake has been relatively slow. Achieving better outcomes in sickle cell is going to require us addressing health disparities, and more education and increased awareness of sickle cell. More doctors who are knowledgeable about their care and continued research are needed to improve outcomes for individuals who living with sickle cell disease. And with that, hopefully I've left some time to answer some questions. Thank you.
Question in the room? I have a question.
Yes.
I think the gene editing, for example, like base editing, is done by in vitro. How it causes the risk of the therapy, for example, like secondary malignancy.
So the question is about. So are you asking specifically about lentiviral or just in general?
Just general base editing, yeah.
So I think that I tried to share with you some of the risks. Some of the risks are associated with busulfan being used as a chemotherapeutic agent. Off-targeting is a theoretical risk, and it persists. And we have to acknowledge that there would be a risk of malignancy if there were an off-target event that occurred in the setting in adjacent to a gene that could be considered an oncogene. I do think that there have been 2 cases of AML, but again, probably not related to gene therapy. But those risks absolutely are there. These are very long, complex conversations with families when we talk about gene therapy. And so it is not for everybody. We're really fortunate at CHOP. We have something called the CURAD clinic, the curative therapies for red cell disorders, where you see a hematologist, a transplant physician, a fertility specialist, a social worker, and a psychologist, all in one very, very, very long clinic visit. Some families are just overwhelmed at the end of that, and they sort of go home and say, I just need to think about this, or no, this is not for me. Others come back with more questions and are ready to move forward. But it does take people some time, sometimes as much as 6 to 9 months before they actually even ready to get to the beginning of this. But there are risks. Yes, there are, and I think today we just need to be very plain about those. And I can't promise that all those risks will be mitigated with in vivo, quite frankly. Yeah.
I noticed in one of the graphs you showed of the trials listed the ages of the participants.
Yes.
It started at 12 and went up.
Yes.
And then both of the gene therapies that are approved for patients 12 and up. And I wonder if you could speak to both decisions about like age of eligibility for the trials. Obviously, sickle cells, the burden of sickle cell, you're a pediatric hematologist, under 12 is substantial. And then decisions about make approval at those ages and how you're thinking about younger kids. You said something about it in Africa, but not in the U.S.
Yeah. So the eligibility criteria in terms of the age is just truly a real concern. So I will tell you that both thalassemia and sickle cell both were initially bounded with the same age limits. The thought being that there would be increased risk of chronic organ injury in sickle cell patients as they age. Yet many of us have been impressed with the number of people as they've gotten older with sickle cell, with good medical care, with high quality medical care, at age 35, at age 37, at age 42, that there really is not a medical reason why they could not actually endure an autologous transplant. Points well taken. Thus far, what we're hearing anecdotally is that there have been institutions that have actually put forward individuals who are over the age of 35 only to be denied by insurers. That the insurers will look at the criteria, and it is certainly an easy target for denial because there's been no one above the age of 35 for which the procedure's been done. I think it's wrong, but having said that, we're stuck with that. Similarly, going below age 12, there are 2 clinical trials, one of which was reported out in December of this past year, looking at patients down to age 5, and they seem to do just as well as people who are older. The expectations are that manufacturer will likely go back to the FDA within the year to ask for their label to be reduced down to at least age 5. Why not go lower? I think it's a fine question as well. The challenge that I see as we go lower is fertility preservation. Right now, we're very comfortable with thinking about fertility preservation with sperm donation and harvesting eggs in mature women. There are experimental techniques using ovarian tissue cryopreservation and testicular stem cell collection through a testicular biopsy. Ovarian tissue cryopreservation has yielded healthy babies. Testicular stem cells have not yet, although they have in non-human primates. And so we have to acknowledge that as we are offering those things to children who are getting chemotherapy for any reason, that it is an unknown on whether or not those people, in fact, will be parents. We don't know that at this point. And so there has to be that part of it that gets added in as a real question mark for families. Having said that, that's been there in the entire area of stem cell transplant, because most successful transplants have invariably caused infertility in people undergoing transplants. And so it is an ethical concern, but it's one that I respect fully, especially in families whose cultures truly, truly, truly value having children. They would rather forego this kind of therapy than risk the possibility of not having a family. Yes.
I was really struck by the slide you showed that it had all the different trials, and you highlighted those that were happening either exclusively or sort of in a hybrid fashion with low and middle income countries. I'm on a DSMB for a stem cell study, so I would love to hear your thoughts, because that was one of the concerns I had looking at it, was thinking about the standard of care varying across study sites, sort of how you think about those issues that arise with standard of care in different places.
I think that's a fair question. There are many people who enter clinical trials so they can get standard of care. And then one could argue that is that in and of itself a form of coercion. I think it just sort of reflects the reality that many of them get far more therapy, far more attention, far more things. Because certainly if we agree that you need to be on penicillin as standard of care, then it needs to be offered to everyone on your clinical trials. And so I think that that it has really been a testament to my colleagues and their collaborators in understanding the environment that they're in terms of how do you run a randomized clinical trial in a place where people may or may not have phones, may or may not have running water, and there may or may not, and in all likelihood, there is a baseline risk of death, usually from malaria in their populations. Not every clinical trial that's been run in sub-Saharan Africa has been successful. In fact, when I mentioned the withdrawal of voxelotor from the market, it was due to deaths on their clinical trial. Some due to malaria, some due to other infections that occurred in Africa. For me, that was actually a clinical trial management issue. That, because many of those deaths occurred months before they were actually notified that they had occurred. And the question was, why were these sites still open? Why was there not some way to reinforce the security for patients on those trials? And so, yes, unfortunately, voxelotor is off the market, but I think Pfizer hopefully will sort of come up with ways to hopefully go back into Africa at some point to begin looking at whether or not there will be benefits of that particular drug. But it has been challenging. Having said that, enrollment in clinical trials in Africa has been brisk. And that many of the findings are actually really very impressive. I don't think that we're prepared to have trials that are only run in Africa to get endpoints approved in the United States, but yet in Africa they're not interested in having trials that are not tested in Africa, and thinking that a U.S. result is sufficient to actually approve a drug in Africa either. So I think it's really an important time for us to continue this conversation. But I think that there really are some caveats to be sure that we are putting in place the guardrails to ensure the safety of people who otherwise are desperately seeking standard care in places like Africa and India.
I wondered if, I think we have time for one more question, so I'll jump in unless anyone else has their hand raised. If you could talk a little bit more about the innovation ecosystem here. So my understanding is that the companies have struggled to stay in this market, in part because of the challenges around insurance coverage of these products, despite the dramatic success that was shown in the studies. And then we also have this challenge about federal funding, especially over the past year, right, where this disease affects marginalized demographic groups that are now disfavored in the funding ecosystem. So how is the field thinking about all of those challenges together?
Yeah, it's definitely all of the above in terms of all the different challenges you mentioned in terms of innovation. I think there are a couple of things. Frankly, there are the issues about having companies that are otherwise innovative being in this space, but being undercapitalized. We certainly have seen that in a couple of really ambitious biopharmas that simply could not weather this, and certainly could not, if they had results that were good, but not great, not having the financial bearings to sort of say, okay, we're going to go back in and we're going to refine this and go out, come in with another clinical trial. They sort of had enough to sort of get them through, if this was really going to be something that you hit out of the park on the first. So some of it had to do with really the environment for biotech. And I would say that biotech right now is a space where innovation is there, but yet risk is, if they don't see a benefit or a result that they're looking for, they cut bait. And so I think we're seeing that across many other conditions. Sickle cell, it makes it easy in certain respects, in my opinion, for some of them. Yet most of them have not done that. To their credit, I think many of us are fearful that given this marginalized population, are you really going to hang in there? Or if you figure out something on sickle cell, then now you're going to go over and take care of cystic fibrosis. Is that we're going to see again? Instead, they really haven't done that. They really have been hung in there. Editas, for instance, there are a couple of the companies that had outstanding results. 95% of their patients were completely disease-free. They have taken the approach that they want to make themselves an in vivo company. And so they are not out of the game. They simply moved over to in vivo, and they have some early results in vivo that look fascinating. And so they've made a decision that's largely based on the business model to focus on in vivo because they believe that in vivo is the future. Anyone coming into this space, so if you're saying that 94% of the patients are pain-free, and you can see fetal hemoglobin levels of above 50%, if you're going to come in with a new product, the bar is pretty high. And so in some ways, if you're coming in with a novel approach, if it does not achieve those, there are many who are asking the question, should you proceed if you cannot get yourself into that range? I would argue that I can probably see clinical benefit at 25% fetal hemoglobin. Yet I think the bar has been set so high that many from a market perspective would say that if I can't get to where say Vertex has been or where Beam is now with base editing, maybe I can't get there. I don't know that the insurance landscape is right now the biggest impediment. I think that our healthcare is complicated. I think that if you have to actually travel across this country, we have patients right now who are in Pittsburgh, and Pittsburgh isn't open yet. So, yeah, you can sort of it's just across the state. But if you are someone with a marginal income and you live in Pittsburgh, being treated in Philadelphia is impossible. We have a couple of patients who are even from like the Lehigh Valley, and it is just difficult to think about having a family and trying to actually take off 6 to 8 weeks of not working, and then probably being immunocompromised for 2 or 3 months when you get home until you're fully recovered, that you can't work. And so I think us trying to figure out those kinds of barriers are also going to be, and those are not part of the insurance equation. There is no one who reimburses you for lost wages. And so I think we have an opportunity to continue to innovate. I think that's where in vivo, in my mind, becomes really very striking in terms of the next step. But for now, the results with ex vivo have been so impressive. And I think that there will continue to be demand for those. It has not been, for all of the discussions, the number of people who are clamoring for that in the commercial setting. The companies have been slow in actually turning around products. That has been noted. As recently, there's an article in the paper in Stat News just last week. The number that these companies can actually turn around is slow. So even the biggest manufacturer for gene therapy cannot get products to you, and it has been a challenge for us. It may take them 3 months, 6 months, even sometimes well beyond 6 months before that product comes back. And for some families, they're waiting, and some of them are like, I can't keep waiting. I have to do something. And so they'll either try another product or they'll just walk away from it for now. It is complex in terms of all the things, but I think as long as we can keep people in the room, the government has a role. There's a Cure Sickle Cell Initiative that was initiated during the, I think the Cure Initiative may have started in the Obama administration, continuing to the Biden administration, that has done some work in trying to support academic centers who have a couple of vectors that are still in the pipeline. But arguably the funding for that initiative is fairly low at this point. And so I don't know how much more we can depend upon from the federal government, but it is what it is.
Right. Thank you very much.
Sure.